All right, picture this. You go in for a totally routine scan, nothing you're worried about. And then your doctor comes back and says, "We found something, a spot on your kidney." Just like that, you're thrown into the middle of a medical detective story. So today, that's what we're going to do. We're going to solve the case of the mysterious renal mass. So, when a radiologist sees that spot, their investigation kicks off with one big question. They have a prime suspect they need to either rule in or rule out right off the bat. Any guesses what that is? Because the answer, well, that's the key to this whole diagnostic puzzle. And here it is. Suspect number 1, renal cell carcinoma, or RCC for short. This is by far the most common type of kidney cancer. So for any radiologist looking at an unknown mass, the mantra is basically, it's RCC until proven otherwise. It shoots straight to the top of the list because it's the one you have to take the most seriously from the get-go. So how do these doctors, start building their case? Well, they look for very specific clues. Does the spotlight light up or enhance when they use contrast dye? Can they see tiny bits of calcium inside it? They also look at the bigger picture, risk factors like smoking or certain genetic syndromes. And here's a crucial detail. If this thing spreads to the bones, the damage it causes is always a specific kind called lytic. This is the official rap sheet for our prime suspect. But of course, the investigation gets more complicated. See, RCC isn't just a lone wolf. It's more like a crime family, with different members who all have their own unique behaviors and personalities. So let's start profiling the key players in this family. And this is a great way to see the lineup. First, you've got clear cell. That's the big boss, the most common and usually the most aggressive of the bunch. It's linked to a genetic condition called von Hippel-Lindau. Then there's papillary, number 2, which is typically less aggressive and sometimes shows up in people who've had a kidney transplant. Medullary is a really nasty one, super aggressive, tied to sickle cell trait, and it often hits younger patients. And finally, chromophobe, which has a key link to another rare syndrome. Each one gives the detectives a slightly different case to solve. Okay, so we've profiled our main suspect and its whole family. But this is where our detective story takes a major plot twist. What if that spot on the kidney isn't a villain at all? What if it's just an imposter? A benign lookalike that's guilty of nothing more than being in the wrong place at the wrong time? And this is where the investigation gets really tricky. Telling a dangerous tumor apart from a harmless one can be one of the biggest challenges in all of radiology. So how in the world do you spot an imposter that's doing its best to look just like the bad guy? Well, let's meet our first imposter, the angiomyolipoma, or AML. This is the most common benign tumor you'll find in the kidney, and it has a secret tell, a key piece of evidence that almost always gives it away. And that secret weapon? It's fat. Macroscopic fat. That is its calling card. Just look at that number. 95%. In the world of medical diagnosis, that is a huge clue. Finding visible fat inside a kidney mass is pretty much a slam dunk for calling it a benign AML. It's the smoking gun that tells the detectives they can probably close this part of the case. But hey, even this imposter has its own case file. AMLs are sometimes linked to a condition called tuberous sclerosis, and they can be a problem if they get too big, over 4 centimeters, because they can bleed. But here's the most crucial clue. An AML should never have calcifications. If you see fat and calcium in the same mass, suspicion swings right back to our prime suspect, RCC. And just to make things tough, about 5% of these guys are lipid poor, meaning they don't have that giveaway fat, which makes them way harder to catch. All right, on to our second benign imposter, the oncocytoma. Now, if the AML is kind of an amateur lookalike, the oncocytoma is a professional master of disguise. Seriously, on many scans, it can look nearly identical to a cancerous RCC, which makes telling them apart with just imaging an incredible challenge. So are there any clues at all? Well, yeah, there are 3 classic textbook signs that every radiologist learns. On a CT or MRI, you might see a scar right in the middle. On an ultrasound, a spoke wheel pattern of blood vessels. And on a PET scan, it usually shows up hotter than the surrounding kidney, while RCC is usually colder. These are the classic tells, at least in theory. But this is where science smacks right into reality. It perfectly lays out the radiologist's dilemma. The practical, real-world radiologist says, look, an enhancing mass like this has to be removed anyway, so let's just call it RCC and be safe. The academic radiologist, on the other hand, might mention oncocytoma in their report to show they're thinking broadly, especially if they see that central scar, because that's the right answer on a test. The truth is, without a biopsy, it's often impossible to be 100% sure just from a picture. So far, every suspect we've looked at has started inside the kidney. But what if the culprit is an outsider? Our investigation now has to widen. We have to start considering tumors that begin somewhere else entirely, and then either spread to the kidney or just happen to grow right next to it. First up on that list is lymphoma. This is actually the most common cancer to metastasize, or spread, to the kidneys. And it's tricky because unlike RCC, which usually forms a distinct ball-like mass, lymphoma tends to just infiltrate the kidney tissue, kind of sneaking in. Sometimes it doesn't even change the kidney's overall shape. It's a much stealthier kind of invader. And finally, we have the liposarcoma. Now, this is a dangerous character that doesn't start in the kidney at all. It grows in the deep space behind your abdomen, called the retroperitoneum. And because it's a fatty tumor growing right next door to the kidney, it can easily be mistaken for a fat-containing RCC or even a benign AML. It's a classic case of mistaken identity just based on its location. And I just love this quote because it sums up the situation perfectly. Fat-containing retroperitoneal lesions should be thought of like a male resident on the mammography service, guilty of all crimes until proven innocent. It just drives home the point that any fatty mass found deep in this part of the body has to be treated with the highest possible level of suspicion. You assume it's malignant until you can prove it's not. So what's the takeaway from all this? It's that a spot on the kidney is almost never an open and shut case. It is a really complex diagnostic mystery. You've got a whole list of suspects, from the obvious villain and its crime family, to the benign imposters, to the outside infiltrators. It takes a really sharp eye and a very careful investigation to get to the truth. And that really leaves us with one last big question to think about. When you have so many potential lookalikes, so much gray area, how do doctors make that final call? How much of their diagnosis is based on pure, objective science from the scans? And how much of it comes down to the art of medicine, that expert intuition they've built over years and years of solving cases just like this one? It's pretty fascinating to think about.